Greetings to the Department of Surgical Oncology at AIIMS. Now we will be taking you through one more interesting case. The theme remains same. If you know the diagnosis and if you know the suspicion or have the suspicion more that, the whole outlook and the philosophy of the treatment changes. But then there are certain situations where we are not very inclined to do so, and it's not mandatorily possible all the time as per guidelines also, neither as per feasibility also. So Dr. Amitabh and his colleague, our senior assistant, Dr. Amit, who will be presenting the case, and Dr. Amitabh will be discussing it. Amit, please.
Good morning, respected teachers and my dear colleagues. I'll be presenting from the Department of Surgical Oncology. Today's PCR, the topic is a bizarre in bile, a rare bile duct tumor. So I'll be starting with the case profile of the patient. She is a middle-aged woman, 40 years, presented with a chief complaint of pain in right upper abdomen for the last 1 month. The pain was dull aching, it was not radiating in nature with intermittent episodes of fever. The pain it was associated with yellowish discoloration of eyes and skin, which is jaundice, and there was no history of weight loss, any history of GI bleeding or change in the bowel habits. There was no history of diarrhea, and there were no symptoms related to hypoglycemia. The patient gives a background history of diabetes, hypertension, and hypothyroidism, and patient was on medications for these comorbidities. There was history of lap cholecystectomy, which was done 2 years back for the gallstone disease, and the family history was not significant, and there were no addictions in the patient. Coming on to the clinical examination, there was no pallor and icterus was clinically present. There was no supraclavicular lymphadenopathy. The performance status of the patient was good. According to ECOG, it was graded 0 or 1. There was no lump palpable and no ascites on an abdominal examination. Coming on to the biochemical test, the liver function test, it shows a cholestatic pattern with rise in the ALP levels and GGT levels, whereas the transaminases were mildly elevated. The tumor marker was that CA 19.9, it was remarkably elevated in the range of 303, and the CA was also elevated, it was 6. The viral markers were negative. Now we have subjected the patient to cross-sectional imaging, which Dr. Shanson will be discussing in detail.
So the patient underwent contrast-enhanced CT and contrast-enhanced MRI with MRCP. These are the axial and the coronal images. In this section, we see that at the proximal CBD and near the primary confluence, there's a well-defined ground to avoid enhancing mass which is noted. It is abutting on the right portal vein, and if we see there is mild bilobar IHBRD which has been caused, and this lesion is seen extending to the right hepatic duct up to the secondary confluence on the right side. The left hepatic duct is completely free. Cholecystectomy clips are seen, and there was no evident periportal lymphadenopathy which was noted. This is a non-contrast T1 weighted scan. Here we see the MR characteristics of the lesion. It's a T1 hyper-intense lesion. It's quite well defined. It's located near the porta hepatis, extending into the proximal CBD and into the right hepatic duct. And on the contrast scans, we see there is peripheral enhancement noted.
So as per the radiological findings, this lesion was a hilar mass. It was a hilar mass which was extending into the right hepatic duct. According to the Bismuth choleratic classification, this was a 3A, type 3A. So the positive findings of this case were an abdominal pain for a duration of 1 month associated with jaundice. Imaging was suggestive of a bile duct mass, whereas biochemical investigations were suggestive of a cholestatic type of pattern. The elevated tumor markers, and this strongly suggests cholangiocarcinoma as a primary diagnosis. We can also think of other differential diagnoses also, as the patient underwent cholecystectomy 2 years back, but we were not having the final histopathological report of that cholecystectomy specimen. So we can think of an enlarged lymph nodal mass at the porta hepatis. And the secondary differential could be a metastatic disease to the porta hepatis, but there was no evidence of any other primary which was located. So after this imaging and investigations, the pre-operative planning started with the calculation of FLR, as the patient will require a right hepatectomy. The FLR was adequate, it was 38%. The patient was having a preserved liver function with the child per class A. The PAC was done, pre-anesthetic checkup was done, and patient was labeled as a high-risk patient due to multiple comorbidities. And after deciding, after a pre-operative planning and optimization, the surgical planning will be an exploratory laparotomy with a right duct excision along with right hepatectomy, with a reconstruction of left duct by Roux-en-Y hepaticojejunostomy. Now I would like to invite Dr. Kirti for the anesthetic workup.
Good afternoon. I'll be discussing the open anesthesia. So we received a 46-year-old 56 kg female with a diagnosis of hilar cholangiocarcinoma, posted for right hepatitis. Our concerns were patient-related and both patient-related and surgery-related. So these were the main considerations. She had comorbidities. She was hypothyroid for 1 year on 15 micrograms OD, and she was euthyroid. And she was diabetic for the past 1 year on dual OHs, and her blood sugars initially were not controlled, and we had taken an endocrinology reference. Her HbA1c was 9.7, and she was preoperatively started on regular insulin on sliding scale. And further, her blood sugars were controlled. She had good effort tolerance of max more than 4. She was not a case of anticipated difficult airway. And surgery related, our main concern was future liver damage after right hepatectomy, which was calculated to be 38%. We have a concern of neuraxial anesthesia with the FL1. Preoperative investigations were majorly normal with HB of 10.8. LFT showed an obstructive pattern and cholestatic pattern with ALP 704. RFPs are normal. Only abnormal investigation was HbA1c 9.7, but later blood sugars were controlled. Cardiac function with ECG and 2D echo were normal. Risk stratification, she came under ASA status class 2, child 2 class A, and revised cardiac risk index class 2, and she was cleared for general anesthesia and a high risk of post-operative hepatic dysfunction. Our plan was GA with endotracheal intubation, and main anesthesia plan was regional anesthesia with intrathecal morphine 5 mg per kg. And we had planned our multimodal anesthesia technique, keeping in mind of the possible post-operative hepatic dysfunction. Epidural was avoided. Intraoperatively, apart from the standard ASA monitors, we had IPV monitoring, left radius line was placed, and right RGV was placed for CVP monitoring. Cardiac output monitor was used for fluid management, early urine output monitoring, early RBS monitoring, and serial ABGs were performed. Fluid management, balanced pistol load solutions were used, and cardiac output monitoring. Intraoperatively, the total blood loss came around 1500 to 1600 ml. Initial HB was 10, considering a transfusion trigger of 8, her allowable blood load was 900 ml. We transfused her 2 PRBCs, 2 RDPs, and 4 plasma intraoperatively. Associated with blood loss, she had hemodynamic instability, hypertension requiring noradrenaline support of maximum dose 0.14 mics per kg per minute. She had hyperglycemic episodes in RBDL ABG, serial ABGs requiring insulin regular IV boxes with early RBS monitoring. Lowest recorded nasopharyngeal temperature was 35 degrees Celsius, and we had used post-air warming devices and warm IV fluids were given. The summary is total duration of surgery was 7 hours, total intake of 2800 ml crystal loads, and 2 PRBC, 2 RDP, and 4 FSP transfusions, and output 600 ml urine output and 1500 ml blood. Lowest nasopharyngeal temperature was 35 degrees Celsius, and the vasopressor support was maximum 0.14 mics per kg per minute. The last ABG at the end of surgery showed metabolic acidosis with a lactate of 5.3 and bicarb of 19.3. Patient was shifted intubated to ICU for further stabilization and monitoring in view of hemodynamic instability.
Good afternoon, everyone. Now I will discussing the intraoperative findings. Here you can see there is a mask. There is the tumor which is arising from the this is the bile duct, from the base of the bile duct. This is the cut end of the dorsal end of the CVD. This is the distal end. And the right hepatic artery in this right, the left hepatic artery. So there is a 3 into 2 centimeter tumor is located in the complex of the bile duct, which is extending to the right hepatic duct to the secondary complex. So we start surgical. I'm not going to using the surgical, but the highlight section of the complex of the bile duct was dissected. Left duct was identified. Left duct was transected with adequate margin, ensuring adequate length of the hepatic vein. The right hepatotomy was performed underneath right duct mass, and the hepatic vein was performed. The 12 trench police rise tube was inserted into the bile duct. Accused anesthetist as state, and the delineation was produced. The nodal clearance was done. Station 8A, station 12A, B, and P. This is the resected specimen, and here you can see the tumor, which is happening in the bile duct. And in the inferior, when you see the inferior, you can see the tumor here. And this is the cut end of the left duct. With high margin, I can able to take. This artery crossing is inserted in the right duct, which was padded. So I'd like to call quickly to this report.
So patient was shifted to ICU, intubated on anatomic support, and she was kept on mechanical ventilation overnight. And anatomic support gradually tapered off overnight, and she was extubated on POD1 morning. On POD1, the analgesia strategy was to give Loxicard plus fentanyl infusion, Loxicard 1.5 mg per kg per hour, and fentanyl infusion at 10 to 12 mics per hour, and paracetamol 500 mg TDS, keeping in view of post-operative deranged liver enzymes. She was observed in ICU for 1 day, and then discharged to ward on POD2. In ward, PCA fentanyl was used as an analgesic strategy along with paracetamol TDS. She was shifted to ward on POD2. She had an uneventful post-operative course. This was a post-operative investigation trends. As expected, she had some kind of coagulopathy at POD2, with INR reaching maximum 1.65 and platelets 64,000 minimum. She did not require any blood transfusion in ICU and her post-op HP was 9.7. Her enzymes were deranged on POD 0 due to the handling of the liver and it gradually came down. And the bilirubin was 2.3 max when it came down.
So, patient was recovered unpreventably in the post-operative period. So, he was started orally on day 5, ICU was moved on day 5, and then was moved to post-operative day 8. We discharged the patient post of day 9 with the ICU, say, ICU. After that, ecology was done through this ICU and post of day 21, that was normal. The pain was given on post of day 21. So you must be thinking why you are discussing this case. It is straightforward case of cholangiocarcinoma with a hepatitis. But the real surprise comes yet to come. The surprise will be revealed by Dr. Sivali.
Good afternoon. So, to our department, we received uh, right hepatectomy specimen, which on serious slicing revealed a hyaline mass. So, this is a well circumscribed or encapsulated gray white homogeneous mass, which was lying in the right hepatic duct. So, sections were taken and paraffin embedded sections examined showed a well circumscribed tumor in the wall of right hepatic duct. We can see the lining proper of the right hepatic duct, but the lining just above the tumor was denuded, but the tumor was lying in the wall and not arising from the epithelium. We can see on a higher power in this section also. So the tumor was a very monomorphic tumor, which was arranged in organoid fashion, organoid and nested architecture with intervening thick and thin fibrous septate. So it was a very classical neuroendocrine tumor, well differentiated type, and the tumor was showing extensive perineural invasion. This is the nerve, and the tumor was showing perineural invasion. Foci of lymphatic lymphovesicular invasion were also seen. Just to confirm, the neuroendocrine tumor, we performed markers, chromogranin and saprofizin were diffusely positive in the tumor, and since CK91 was performed because it has a role in the prognosis. CK19 was positive in these tumor cells and it reveals a very poor prognostic factor in neuroendocrine tumor of the pancreaticobiliary system. And to grade the tumor, we performed KI67, proliferation index was 8 to 10%, which made it a well differentiated neuroendocrine tumor grade 2. Concluding that it was showing extensive PNI, LVI, or immunohistochemistry tumor cells were diffusely positive for chromogranin, saprofizin, and also for CK19. And the left hepatic duct margin was 1 mm away with no infiltration into the adjacent liver parenchyma. All other margins were also free of tumor. There were also additionally 5 lymph nodes dissected, which were showing only reactive hyperplasia and no metastasis. So further we will discuss.
The case was discussed in MDD, but there's no treatment or we planned for a total scan. And the patient was operated just last month, so it is yet to be done. So the follow-up is structural follow-up is very important. So for clinical evaluation, they have to LFT within 2 to 6 months and scan every 6 to 12 months, as well as serum biomarkers over a day. So these are the NCCN guidelines for extrahepatic cholangiocarcinoma. For diagnosis of the cholangiocarcinoma, we have to do this investigation like routine blood, CA, CA99, multiplicity CT, MRCT, is the preferred investigation. So for management, for hyaline cholangiocarcinoma, is the basic principle is to receive the bile duct, or if necessary they affected heavy liver with a negative margin, and this is one of the total nodes. For distal cholangiocarcinoma, it is penetrated that is with this possible. For unresectable cases, if there is a certain biliary system, we can biliary drainage after the secondary update started. For metastatic disease, we can start chemotherapy, or if the PS is good, if the PS is not consistent chemotherapy, we can use this. Yeah. So neuroendocrine tumor are the heterogeneous group of neuroplasm arising from the neural cells distributed throughout the body. The incidence is gradually increasing with the diagnosis of the diagnostic modalities. The major location is the GI tract, pancreas, and the lungs. So extrahepatic biliary NET is exceptionally rare. The 200 cases has been reported so far in the literature. The first case was described in 1961. It is representing the 0.3% of the GI NETs. Within the biliary tract, the most frequent location is the CBD and CHD. So there is a literature review which shows a median age of 47 years in female predominance, symptomatic in 85% of the cases. The symptoms are related to the tumor mass, growth in medical diagnosis structures, or metastasis. The most common symptoms may be jaundice, pruritus, 99% of cases are related to the symptoms. The most frequent sites are the common hepatic duct, distal cone, bile duct, middle of the cone hepatic duct, cystic duct, proximal bile duct, but there is no mention of the complex. So the peculiarity of cases is the involvement of the complex, the excess in the right duct. So these are the comparison between extrahepatic biliary NET with cholangiocarcinoma. So we can see that these are the neuroendocrine origin. It's a very rare tumor, but the cholangiocarcinoma most common biliary tumor. The growth rate is in case of extrahepatic biliary is very slow and is very aggressive. Prognosis is excellent in these cases with a high 10-year survival rate. But in cholangiocarcinoma, prognosis is not good in comparison to extrahepatic biliary NET. So the symptoms are almost same. If there is no GI symptom, may be present in case of NET, but in case of the GI symptoms may be absent. So imaging, there is we cannot detect, we cannot confirm say that on imaging that it is a extrahepatic biliary NET. So the imaging findings is almost the same. The treatment is mainly surgical in extrahepatic biliary NET. Chemotherapy and radiotherapy has no role. So key point, the radical resection is the cornerstone of management for localized biliary NET. Adjuvant therapy was not indicated. Post-operative follow-up is very critical. Recurrence is less frequent, but 30% has been reported. The biomarkers monitoring should be done. To conclude, the extrahepatic biliary NET is a rare tumor. Not all biliary masses are cholangiocarcinoma. So high index of suspicion should be there if the GI symptoms are present and non-sympathizing mass of the CT. And aggressive surgical management is the curative option. So to conclude the session, I would like to
Thanks, Amitabh. So anyone who has followed the scans and the history, actually there is nothing fitting in classical biliary tract tumor. Because number one, biopsy is generally not required. We go ahead, and most of the time it doesn't bleed fast. Number two is that the biomarker, tumor marker, which is expected to be in a kind of 1,000 or plus or something. Again, this is very much in the moderate range. If you recall the MRI, again, most of the extrahepatic cholangiocarcinoma or even higher cholangiocarcinoma will be cicatrizing in nature. So there is just no mass. So if there is no mass, you can't get biopsy. That's the biggest problem. And that's the reason most of the time we have to go with the surgery as a direct if all is treated or curatively resected. A proliferative pattern that goes against that. So we were not all through it was like, but there is nothing against the diagnosis of extrahepatic or hilar cholangiocarcinoma, and the liver quality was relatively good. And that's a critical difference. Because if someone is having a bilirubin of 2 with obstructive pattern, all the more you tend to think, because most of the patients with hilar cholangio, they will be presenting with bilirubin which is at least 10 plus, more than 10 plus. So if you go ahead and operate them directly, that's the real havoc to the patient. They can't sustain it because the liver function is so deranged, and on top of that, you remove the 2/3 of the liver, it just crashes. So that's the biggest dilemma, that whether to offer surgery immediately or not. If I'm given that biopsy beforehand, yes, how I am wiser that even if the patient's condition is not that great, but there is no other choice for treatment, and I have to go for surgical treatment if at all that is, even at the kind of affordable risk or whatever. And this risk was borderline in this scenario, 35 to 38%. Now, 35 to 38% in a patient with cholangiocarcinoma is much very different compared to a patient with any other relatively benign pathology like neuroendocrine. Simply because back pressure changes are not that great, liver quality is relatively much better. So even if you knock out almost 2/3 of the liver, that is very much likely to sustain compared to a case of long-standing jaundice like in hypertension. So we have to take a call, and based on that calculated risk, surgery remains same, yes, true, but then the sustenance and the tolerance to surgery is something which is going to make a difference. Thank you so much for your patient listening, and if there are any questions, then we will move on to Yeah. Simply because all the time we are biased with cholangiocarcinoma, CA99 is raised, there is a mass in the thyroid, AFP is negative. So progranulin comes only at in the picture when we do have some suspicion about that. We will do that, but only problem is it costs minimum $7,000 for every determination. So and we are not offering here to So and same goes for Dotanoc also, but then Sunil has left, so they are kind enough to do most of the free.
So I have two questions. One is, most of the cholangiocarcinomas, localized cholangiocarcinomas may have been presented with a degree of jaundice. So, is there any clinics practically, do you have a cutoff roughly that this is the bilirubin level? Because there are also concerns of pre-operative stenting that has been raised in you should straightaway go for a surgery rather than stenting. There are some concern and literature regarding that. So in clinics, as a medical oncologist, when should we be after that we should not really think of, because it is very natural there will be back pressure changes. So first question is this: what bilirubin level roughly you feel that above that is practically not possible? And the second thing is, as you said, 38% in such cases, as cholangio or I would take it as cholangio. So by chance, I might say any issue. Also with the patient. Yeah. So what percentage of FLR is comfortable doable for a patient?
Okay, coming to the first question, that how much is the bilirubin you expect? The worst thing about these patients with hilar cholangio, I'm not talking about the extrahepatic biliary person, but hilar cholangio, stenting, routine stenting, endoscopic stenting will not work because they are high up and gastroenterologists, they are not comfortable going because both the ducts are low and the confluence is not great. So most of the time you will end up with PGD. That's number one. Difference between a low jaundice of 2 versus a common presentation of more than 10 plus is that longer the jaundice has been there, the liver function, derangement of liver function is quite long standing. And recovery is also proportionately very slow. And those 2-3 days are very critical for that in the immediate post of period. So if you go ahead and operate in that kind of situation with 10 plus bilirubin, you have to have bile leak, and in all probability patient will crash because of the slow recovery of the liver. So we don't do that. So we always go for, if the bilirubin is 10 plus or so, unless patient is really, attack kind of thing, Then you go for PTBD, come down to at least less than 5, maybe preferably less than 3. And basic marker is that your rest of the liver parameters should be good enough. Because most of the time the problem occurs because of the bleeding problem. And that is because of the, again, deranged INR. So artificially corrected INR is not acceptable. It should be by virtue of lowering down the bilirubin and the drainage so that the natural recovery of the liver function is. Now coming to the second part of the question, that how much is the FLR? So there are a couple of riders in that. 38% alcoholic patient, answer is no. 38% non-alcoholic patient without any prior history of hepatitis, answer is yes. So it's not just about one figure, but coexisting issues. Liver dissection is the kind of holy grail that how do you take your call, whom to operate, whom not. So 35% is in general the figure we can accept, but the rider is that the rest of the liver parenchymal quality should be close to normal. And that's the reason, out of context, even in liver transplant, first thing they do when they accept the organ is to do the liver biopsy to rule out alcoholic steatosis. That fatty liver you rule out, although liver looks normal, but if the component of fatty liver is above certain limit, that organ will not be accepted. So, what percentage is just a rough calculation. To some extent, fibroscan does help, but in a jaundice patient and heavily jaundice patient, that finding is also not very good.
One question. So when we know it is a liver tumor post surgery, what would the resection be lesser than what we did, or would it be same?
Unfortunately, wide duct involvement compels you to lose the parenchyma. There is no way we can substitute for it. And here, if the secondary level confluence is involved, we are forced to throw the right lobe completely. Difference will be there. Yes, if I had known the histological diagnosis, whether I would have gone with 30% of liver, remnant liver, yes or no. If you had asked me, then I would have been fixed. Probably we would have taken the risk. 30 is a borderline kind of thing. Other option was to kind of go for total venous embolization, so that even if 5 to 8% kind of increment post embolization can be afforded, because neuroendocrine gives you a little bit of time compared to cholesterol. Most of the time it goes if the patient is symptomatic. If the patients are not symptomatic, we generally, not we will not be insisting for going for the insulinoma studies or even the serotonin level or something like that. Correct. Yes. Yes. And
The point seemed very blank because nothing happened. But
no. Constant tumor. Yes. I certainly agree with you. The fallacy about neuroendocrine tumor is that it will be symptomatic only when there are a lot of liver metastases. Now, if I put the question back again, in presence of liver metastasis, if we would have operated, answer is again yes. Because then we are compelled to do so. There is no other treatment. Absolutely. That's the reason why symptoms occur. True.
Functional people, they have a background and they are symptomatic. See, every next is not functional. So non-functional still won't.
And why I said that even at the 30%, you would have gone for surgery because of 10-year survival is more than 90%.
It's mostly non-functional. In this case, because this patient had diabetes, there is a theoretical risk that it could be secreting so much.
Possible.
You
Possible.
should look for what is happening to diabetes.
Yeah.
There is a proper possibility of that. Say if you look for primary the
We are planning to get a Rotanop also, so hopefully that should come up because endoscopy was normal and yeah, we expect to get some kind of answer in on that front through Rotanop, and if at all something is suspicious, we will be going for endoscopic ultrasound.
May not be picked up on a
Mucosa looks normal most of the time. Thank you so much.